Well, just to introduce myself, my name is Shireen Olivieri. I'm a graduate of the University of South Carolina in Columbia, South Carolina in the year 2000. After that, I completed my PGY1 at the University of California, San Francisco, and I stayed there on faculty for about 7 years. I'm currently an associate professor at Midwestern University in Glendale, Arizona. And with that, we're going to go ahead and get started. We have a pretty packed agenda. I have no conflicts of interest to disclose. The learning objectives are there listed for you on page 410. In the interest of time, I'm just going to allow you to read that on your own. The agenda today, we're going to be talking about 6 different topics, so it will be very fast. We have menopause, osteoporosis, pregnancy and lactation, contraception, sexually transmitted infections, and sexual dysfunction in men. So each of these topics can easily take 2 to 3 hours per topic, so it is going to be pretty quick, fortunately. We're going to go ahead and start with menopause. If you'd like to turn to page 413 in your books, our first case. EL is a 50-year-old woman with hot flashes and vaginal irritation. She's tried exercise, diet, antidepressants, and has been unsuccessful. She's otherwise healthy, no history of cancer, and no surgeries. She states that her hot flashes are interfering with her daily activities and wants to try hormone therapy. So, which of the following was proved statistically significant with conjugated estrogens and medroxyprogesterone acetate, and should be mentioned to EL? Which of the following risks? So we have increased risk of DVT, decreased risk of stroke, decreased risk of MI, or increased risk of fractures, which we'll talk about next. A second part of that case is if we're going to treat this patient, what do we treat them with? We have an estrogen patch, we have vaginal cream, conjugated estrogens, and medroxyprogesterone acetate in the oral tablet form, or just conjugated estrogens. Okay, so let's quickly review menopause, some of the signs and symptoms. Menopause, generally, the average age is 51 years for onset, and that is cessation of menstrual periods for at least 12 months. The ones that I want to have you bring your attention to include the vasomotor symptoms, night sweats, and genital urinary atrophy, which are specifically related to estrogen deficiency. What hormone regimens do we have on page 416? We have unopposed estrogen. Unopposed estrogen is only for women that do not have a uterus. If the patient has an intact uterus, she will require a progestogen to prevent the risk of endometrial cancer. And that was shown to us by the PEPI trial some years ago. For women that do have a uterus, they can use a variety of different regimens. We can use an estrogen plus a cyclic progestogen. Progestogen is the term, it's the umbrella term for natural progesterone and synthetic progesterone known as progestins. So the new terminology, you may have been familiar maybe with just progesterone or just progestin. The new terminology is progestogen, and you'll see that more and more in the literature. With this, the patient would take the estrogen daily, and then the last 10 to 14 days of the cycle, she would take progestogen. We have estrogen plus daily progestogen, where every day the patient is taking estrogen and taking a progestogen as well. The regimen was studied in the HERS study and also the Women's Health Initiative, some of the more well-known studies. And then we have estrogen and intermittent progestogen. This isn't used that often, but the estrogen is given daily, and then the progestin is given 3 days on, 3 days off. We rarely see this, but just something to be aware of. Okay, a summary of the Women's Health Initiative findings, which came out some years ago in 2002. There is a summary on page 415. We can see that heart attacks, breast cancer, strokes, and blood clots all increased with the use of conjugated estrogens and medroxyprogesterone acetate. Hip fractures and colon cancer actually decreased, and then dementia in a different study actually increased as well with estrogen therapy. So, going back to our patient case 1, question 1, which of the following was proved statistically significant with conjugated estrogens and medroxyprogesterone acetate and should be mentioned to EL? Raise your cards. Okay, good. I'm seeing some people show blue, and blue is the answer. There was increased risk of DVT. Okay, which of the following hormone treatments, hormone therapy treatments, would be good for EL? So we have the estrogen patch, the vaginal cream, conjugated estrogens, and conjugated estrogen plus progestin, and then just conjugated estrogens. Any cards? Because that's supposed to. All right, well, we'll just continue. The answer was C, conjugated estrogens. Also, for vaginal symptoms, in the event that it's only vaginal symptoms, you're going to recommend that the patient use a local therapy, a local estrogen, versus using a systemic therapy. In those cases, you do not have to have a progestogen added to that if they're using just the local vaginal cream. Sexual dysfunction, hormone therapy is not recommended. In urinary health, systemic hormone therapy may worsen stress incontinence. However, the local therapy may actually help overactive bladder. So a little bit of a pro and con there. And then for osteoporosis, it's indicated for prevention if other therapies have been shown not to work. Other recommendations, so the risks that we've outlined, venous thromboembolism, cardiovascular disease. The Women's Health Initiative trials were criticized because the average age of the woman was much older than when menopause actually occurs. So a majority of the women in those trials, their average age was around 65, whereas menopause actually, the onset's around 50, 51. So we see that the risk for cardiovascular disease actually increases the further out that the patient has been from menopause. So if you start hormone therapy, 10 years after the patient went into menopause, that's where we're starting to see some of those risks. Breast cancer, we have seen the increase usually after 3 to 5 years of use. Estrogen alone has a different risk profile, however, we still do see an increase. And cognitive function, we mentioned, also deteriorates as well. Additional data is needed for ovarian and lung cancer. There is some data out there to show that perhaps there is an increase in both of those cancers, but those patients had a lot of confounding variables that we don't have some definitive information on that yet. The bottom line for the recommendations is that therapy should be with the lowest dose possible. We want to check after 3 months to 1 year to see if the patient is asymptomatic. If symptoms reoccur, then you want to treat again for another 3 months, and it's best to keep the treatment less than 5 years. Contraindications, if you get a patient case and the patient has a history of breast cancer, cardiovascular disease, stroke, or history of blood clots, then you would not want to recommend hormone therapy in these patients. Alternatives for those patients can include, for the vasomotor symptoms, we can include SSRIs, particularly fluoxetine and paroxetine. Venlafaxine may also be used as well, and these have been shown to decrease the frequency and severity of hot flashes in women. Some others with some less data include clonidine, megestrol, gabapentin, and then some of the natural products that are soy-based or herbal products. Okay, so our patient case 1, question 2. So I apologize, I think it's just a different set. EL, if we look at her and we're assessing her, does she need therapy? The hot flashes and vaginal irritation, so she's having systemic plus local. And then also she doesn't have a history of cancer and she doesn't have a history of surgery, so we can assume that she has an intact uterus. The symptoms are interfering with her daily activities, so she does need therapy. And in this case, I know I had asked this just previously, the answer was C. She needs a conjugated estrogen and a progestogen because she does have an intact uterus. Answers A and B would not be appropriate, or D, because they're only estrogen, and B on top of that would only address the local symptoms and not the systemic ones. Okay. There's a reference for you within your booklet for the 2012 position statement from the North American Menopause Society. I do recommend that you review this. It will aid you in your studying. Right, osteoporosis. We will go to page 419. We have patient case 2, question 3. Our case is a 71-year-old female with a history of rheumatoid arthritis who smokes half a pack per day. She takes calcium, 1,200 milligrams in divided doses, and vitamin D, 600 international units per day. We have her height and weight. She has a T-score of negative 2.6 at the hip and negative 2.1 at the spine. Her FRAX score for a 10-year major fracture risk of is 22%, and for a hip fracture is 11%. So you're going to want to take in all this information as you assess this question. Which of the following statements best describes the correct diagnosis for RK? Is it going to be the normal bone mineral density of the spine, osteopenia of the spine, osteoporosis of the spine, or osteoporosis is defined when a fracture has occurred. The second part of this case is going to be how do we treat this patient. So the options that we have are teriparatide, alendronate, 35 milligrams, miacalcin, or risedronate. So let's talk about definitions of osteoporosis. The World Health Organization defines osteoporosis as those patients that have a bone mineral density of less than 2.5 standard deviations from that of the young adult mean. Normal is considered having a BMD within 1 standard deviation, and osteopenia, or low bone mass, is between -1 and -2.5. So you can kind of think about where our patient was at. Some of the risk factors, this is important to note when you're assessing the questions. You want to be looking at what risk factors the question is giving you. This will help you determine if the patient needs screening or treatment or just lifestyle modifications. Some of the risk factors include being female, white race, poor nutrition. So poor nutrition can range from just not having calcium and vitamin D in the diet, having low body mass, also, anything that's related to estrogen deficiency, so if the patient went into menopause early or has long-standing amenorrhea, also family history of osteoporosis, or anything that puts the patient at a fall risk. So for example, if they have dementia or their eyesight is not very good, or they had a history of previous falls or fractures. The other thing to really focus on is the drugs. Which drugs are going to contribute to osteoporosis? And so you really want to focus on that, because a lot of times in the questions they'll tell you that the patient's on certain drugs, and they want you to kind of be thinking about that. So glucocorticoids longer than 3 months is going to be a risk factor. Heparin, long-term use, as well as anticonvulsants, or excessive levothyroxine. So if they give you a TSH level and you can see that it's abnormal, GnRH agonists, lithium, or cancer drugs are all going to contribute to the risk of osteoporosis. Okay, how do we assess risk? How do we assess risk of osteoporosis? So we have something called the FRAX score. How many of you are familiar with this? Okay, just a few. Okay, so the FRAX score is fairly new within the past couple of years. There is a website for it. You can go in. It's a tool. You enter in these different risk factors of the patient. You do need to have the femoral neck bone mineral density to use this tool. And you enter in all this stuff, and it spits out a risk factor, or sorry, a risk, 10-year risk for the hip fracture or major osteoporotic fracture. And from that, we can tell if the patient should probably be a good candidate for therapy or not. The gold standard, however, is going to be the bone mineral density testing, or the DEXA, known as the dual energy X-ray absorptiometry. This actually is the gold standard for telling us what the patient's risk is. When do we screen women? Who should have their bone mineral density checked? All women older than 65 years need to have their bone mineral density checked. Postmenopausal women that have medical issues that may cause osteoporosis should be checked as well. And then younger women, age 50, who have risk factors should be screened as well. And then any postmenopausal woman that has had history of a fragility fracture should be screened as well. And a fragility fracture is if the patient is standing and from a standing position somehow snaps a bone and has a fracture just from standing. They didn't fall or anything. Okay, what about men? In men, anyone older than 70 years of age should be screened. Men that are younger, ages 50 to 70, should be screened if they have previous fractures or have risk factors. So what are some recommendations? We want to advise the patient to avoid smoking and avoid high use of alcohol. These are risk factors. We want to encourage weight-bearing exercise and muscle strengthening exercises. Even walking 30 minutes a day can be considered a weight-bearing exercise. And then encouraging adequate intake of calcium of at least 1,000 milligrams per day and vitamin D, 600 to 800 international units for those that are younger than 70, and those that are older than 70, 800 to 1,000. Now, the U.S. Preventive Services Task Force came out recently within the past couple months saying that they did not see any difference or any reason that patients should be taking vitamin D and calcium. They didn't see any effect for postmenopausal women and fractures. So the question is, do patients really need to be supplementing with vitamin D and calcium? And there's been a lot of debate about this. The National Osteoporosis Foundation did reply back and send out a statement saying that they do feel that this still is really important. It doesn't necessarily prevent fractures, but it is in combination with other things that it can prevent fractures. So still the recommendation is that patients should be getting calcium and vitamin D. However, where they're getting it from is best to be getting it from their diet and not necessarily having to over-supplement if they're already getting it from their diet. The other thing you want to do is assess fall risks and make sure that the patient doesn't have cords or anything in their home, if they need assistance or anything like that, or going upstairs, to make sure that those patients have the care that they need. Okay, so going back to our question here, which of the following statements best describes the correct diagnosis for RK? And we have our options there. What do we see here? Okay, see a lot of red. Okay, the answer is B. What I do want to bring your attention to, though, however, is make sure that you read the answer choices, because you might look at this and say, well, it's negative 2.6 at the hip, so it's osteoporosis. But the question's actually asking about what's going on at the spine. So be cognizant of what is in the question. Based on the National Osteoporosis Foundation, the American Association of Clinical Endocrinologists, and the North American Menopause Society, recommendations for initiating pharmacotherapy: when do we treat the patient? If they've had a hip or spine fracture, if their T-score is -2 or lower at the hip, spine, or femoral neck, or if their T-score is between -1 and -2.5, and they have the FRAX score showing that their probability of a hip fracture in the next 10 years is greater than 3%, or a major osteoporotic fracture within a greater than 20%. So if you think about our patient and her FRAX score and her T-scores, you know, she qualifies for initiating pharmacotherapy. So what pharmacotherapy can be given? We have bisphosphonates. Those are generally the first line. We have selective estrogen receptor modulators, calcitonin, teriparatide, denosumab, and hormone therapy. Quick review of bisphosphonates: they inhibit osteoclasts and reduce bone resorption. So osteoclasts, if you remember, that is the cells that actually cut down the bone and increase calcium in the blood. So these actually inhibit those cells. We have good data with it to reduce vertebral fractures as well as hip fractures. We also have some side effects that we need to look out for, which are mainly esophageal or gastric irritation. And because of that, and also its absorption, we recommend patients to take it on an empty stomach and to remain upright for at least 30 minutes. For Ibandronate, it needs to be at least 60 minutes, so there's a little bit of a difference there. And then with a delayed release Risedronate, it's actually taken after breakfast. So this is a key kind of change between some of the agents. Also, if the patients have a low GFR, so less than 30, then these agents may not be the best choices for those patients. Additional risks include osteonecrosis of the jaw. These are usually seen in patients that have had cancer or in patients that recently had tooth extractions. Those are where we might see something like this, although they're fairly rare. And then there's been some information about atypical fractures. However, the FDA has not recommended against the use of bisphosphonates at this time. Looking at a list of some of the bisphosphonates, we have alendronate, which can be daily or weekly dosing, risedronate, daily, weekly, or monthly. We have the delayed release, and then we have Bonivo, which can be given IV every 3 months, or zoledronic acid, which can be yearly or every 2 years for prevention. Raloxifene is a selective estrogen receptor modulator. It's approved for prevention and treatment. We do have some good data with this for preventing vertebral fractures, but not hip fractures. So this is important as well when you're looking at the question to see what they're actually wanting you to treat and where the T-scores are low. Some of the adverse effects can be increased VTE or hot flashes or leg cramps. Okay. Other therapies, calcitonin, this is our intranasal therapy. and it's generally good for reducing vertebral fractures only, not hip fractures. It's good for bone pain. However, the FDA recently had an advisory panel recommend that the risks of this actually outweigh the benefits. We have seen some cancer cases with this agent, and likely it will be removed off the market in the next year or so. Teriparatide is recombinant human parathyroid hormone. This actually builds bone. We usually reserve this for more severe cases of osteoporosis, and it's used as an injection subcutaneously, 20 micrograms per day, up to 24 months. There has been a risk of osteosarcoma with these patients, so that is something to monitor. Sorry, with animals, not in patients, but something to monitor in the patients. Denosumab is our newer agent that's been out a few years. It inhibits osteoclasts, the bone resorption that's mediated by the osteoclasts, and it does this actually through a monoclonal antibody, which is kind of different from the other agents. It binds to the receptor activator of the nuclear factor kappa beta ligand, and this is a cytokine that actually is essential for the formation of bone and function of, formation, function, and survival of the osteoclast. That if we inhibit this, we inhibit the osteoclastic activity, which then we inhibit bone resorption. It's dosed 60 milligrams subcutaneously every 6 months. It's fairly expensive. We do have some good data with it. It builds bone and prevents some of our fracture risks. Some of the safety issues to look out for include possible infections and then also low calcium. Hormone therapy, that is approved for prevention only, and again, it's only used in the cases where these alternate therapies are not available for the patient. Okay. So the second part of our question here, question 4, when we're looking at the treatment for this patient, does the patient require therapy? Yes, if we were looking at her risk factors, we have her age, she's a white woman, she has a history of rheumatoid arthritis, she's a smoker. Also, she is taking calcium and vitamin D, which is great, but we do have a T-score of negative 2.6, which puts her automatically to initiate pharmacotherapy. In addition, she has negative 2.1 at the spine, and also her FRAX score is fairly high. She has a risk of 22% for a major fracture and a risk of 11%, which, according to our criteria, indicates a need for therapy. So what therapy would be appropriate from the choices? Okay, I'm seeing some yellows, good, and that is the correct answer. So A would not be correct because teriparatide, again, we save that for more severe forms. It's not first line. Alendronate 35 milligrams. Alendronate is a good agent to use. However, 35 milligrams is the preventive dose that we usually give if the patient's on glucocorticoids long term, so that would not be appropriate. The nasal spray, again, we said that that's a little bit later down the line and actually may be removed from the market. So Rezidronate is the correct dosing. In addition, you want to look at the vitamin D. It needs to increase a little bit to 800 international units since the patient is older than 70. There's some references there listed for you. Again, if you'd like to review a little bit more in depth some of the guidelines, these are some good resources for you. Pregnancy and lactation. We're going to switch gears now. And on page 427, SE is a 28-year-old woman who would like to get pregnant soon. Her medical history includes hypertension, seasonal allergies, and we have the drugs listed there, lisinopril, nasal saline spray, and folic acid. Which of the following would be best to treat her hypertension while she's trying to conceive? We have continue lisinopril, discontinue lisinopril and all other medications, discontinue lisinopril and start methyldopa, or continue lisinopril and add atenolol. Let's talk about drug use in pregnancy and what are some things that you need to consider. The general approach, you want to assess the drug use if the patient's trying to conceive. So does the patient need the medication? Is the medication a teratogen? As a reminder, a teratogen is a drug or environmental agent that has the potential to cause abnormal fetal growth or development. You want to make sure the patient is on folic acid a minimum of 400 micrograms per day prior to conception, and definitely within the first 12 to 15 days after conception. Through the pregnancy, we can increase up to 600 micrograms. Most formulations have about 800 to 1,000 micrograms in their vitamins. You want to consider the trimester and the timing of the medication. So some medications are teratogenic in specific trimesters, but okay in others. So if the patient's already pregnant, you want to know what trimester they're in, and those questions might provide that. Also, you want to assess the drug's safety versus benefit. So not all drugs are bad in pregnancy, and some are required to treat some serious conditions that the mother has. So you want to weigh the risk versus benefit. Looking at the pregnancy risk classifications the FDA has put out, this likely is going to be going away. They've been saying that now for a couple of years, but I think this year is kind of finally the time that they're going to remove these. But since they're still in effect, it's good to know that category A and B are generally considered okay to use in pregnancy. If possible, you want to avoid C and D, although you want to weigh the risk versus benefit. And then contraindicated in pregnancy is category X. It's important to note, though, that not all category X drugs are teratogenic. Birth control pills is an example. It's category X, but if the patient happened to be taking it while she was pregnant on accident, it's not necessarily teratogenic, but patients might see this category X and worry about that. So important to kind of differentiate between that. The new labeling is going to be more extensive, and it's going to be within the package inserts. Okay, known teratogens on page 426. The BPS domain, kind of the guide of what's on the exam, lists that isotretinoin to know about the program that regulates this. This is called the I-Pledge program, and this is where the pharmacy, the physician, and the patient are registered. It's showing that the patient is not pregnant and that she's pledging to use 2 forms of birth control. Some of the other more well-known teratogens, methotrexate, warfarin, ACE inhibitors, statins, those are things that you want to make sure that your patient is not on if they're trying to conceive. Some of the conditions in pregnancy and the key concepts, if they're having severe nausea and vomiting, vitamin B6, some antihistamines, and ondansetron or metoclopramide can generally be used. If the patient's having a headache, acetaminophen is going to be our drug of choice and not NSAIDs. Particularly in the 3rd trimester, you want to avoid NSAIDs. Coagulation disorders, the drug of choice is going to be the low molecular weight heparins, such as enoxaparin. You can use heparin as well, but you just need to monitor the patient for osteoporosis as well as the fetus. Generally, we avoid warfarin as well. Diabetes, insulin is preferred, though in some patients that are afraid of needles or cannot use insulin for some reason, we do have some data with sulfonylureas such as glyburide and metformin that do have some data, but insulin is the preferred agent. Hypertension, patients, we can use calcium channel blockers or beta blockers. The drug of choice, however, is going to be methyl-dopa. And within the beta blockers, we want to avoid atenolol because it has a risk of intrauterine growth retardation. So looking back at our patient, we have any answers? What can we do? We have any answers? Okay, I'm seeing some green. So the answer is discontinue lisinopril and start methyl-dopa. Right. Drug use and lactation, you may see some questions related to this as well. You want to consider the risk versus benefit of the medication and the treatment that's needed. We can do a couple of things. We can do pump and dump or pump and save, which is where the woman will pump her breast milk at the highest peak concentration time and dump that milk, or right before taking her dose, pump her milk and save that milk for the baby. You want to pick drugs that are shorter half-lives and also assess the drug. Those that enter breast milk are those that are highly lipid soluble, are in high concentration within the mother's plasma, those that are low in molecular weight or low in protein binding. Okay, and we're on to contraception. Okay, page 432 to 433. We have a variety of different contraceptive methods. We have combined hormonal contraceptives, progestin only, and non-hormonal, and we'll go into each of these. So we have our patient case on page 433, question 6. KR is a 22-year-old woman initiated on Merced 4 months ago for contraception. She has breakthrough bleeding at the start of her active pills that last for the first few days before resolving, and the physician wants to change the oral contraceptive. Which of the following OCs on her formulary is the best to prescribe? So we have continue on Merced for another 3 months, change to Orthocep, change to Lacina, or change to Loestrin 21. You may be given a chart like this along with the question. So how do we assess this? How do we figure this out? Let's talk quickly about the contraindications, first of all, related to combined hormonal contraceptives. Listed here are the Category 4 contraindications from the World Health Organization, meaning that combined hormonal contraceptives should not be used in this patient. So patients that are less than 3 to 6 weeks postpartum, they may be at increased risk for DVT. Other risks for DVT may be major surgery with prolonged immobilization, known thrombogenic mutations. If they have a history of cardiovascular disease or ischemic heart disease, vascular disease, then those are also at risk. If the blood pressure is uncontrolled, greater than 160/100, then the chance, estrogen usually increases blood pressure, so we could put the patient at risk for possibly stroke or hypertensive emergency urgency. Any issues with the liver, the hormones are metabolized through the liver, and then any risk factors for stroke can also be an issue, and that could include a migraine with an aura. The key there is the migraine with the aura. We've seen that patients have an increased risk of stroke if they have an aura with their migraines. If they're older than 35 and they have a history of migraines, then that also potentially can be a contraindication. Current breast cancer, also we don't want to use hormones in those patients, so that would be contraindicated. Some of the side effects that are associated with each component, the estrogenic, and there's a nice list for you on 434. Generally nausea and vomiting or breast tenderness, hypertension is associated with the estrogen component. Progestational or androgenic can be hair loss, acne, changes in libido. How do we manage these side effects? We have this patient comes in, she's got nausea, what are we going to do? We can usually guess that this is related to the estrogen component. We can tell the patient to take the tablet at bedtime or take it with food. We usually recommend that the patient continue on the product for at least 3 months because usually these side effects go away with time. However, if it's truly bothersome, then we can switch the product. Acne, sometimes patients will break out on certain birth control products, and usually that means we need to lower the androgenic component of it. We can also increase the estrogen component of it. Estrogen increases sex hormone binding globulin, and this actually binds androgens in the blood and helps androgenic mediated acne. For breakthrough bleeding, if unexpected bleeding occurs, the patient should use a different form of contraception until that ceases. We also want to assess that patient to make sure that the bleeding isn't coming from something else. Once we know for sure that it is the birth control pills, then we can assess that bleeding and decide how to change it. Usually with breakthrough bleeding, if the patient continues for 3 months, the breakthrough bleeding usually goes away. But if it continues, then we definitely want to change it. We want to increase the estrogen dose when the bleeding occurs within the first 14 days of the cycle. And this is because estrogen builds the endometrial lining of the uterus. So if the patient's having breakthrough bleeding, that means we're not having enough estrogen in the beginning of the cycle, and we need to add to that. This also is with withdrawal menses. Withdrawal menses means that the patient is not getting their period when they're on the placebo pills. And that also indicates that there's not enough estrogen. Or if they just don't get a period at all, that means that the lining didn't build up enough and we need to increase that estrogen dose. If the menses continues into the active cycle, then at that point, that's still considered early in the cycle and we would want to increase the estrogen dose. When do we change the progestin dose? So estrogen is early. You can remember estrogen E early, progestin is late. Begins after after day 14, and we can increase the progestin or their progestational or androgenic properties. You want to increase both if bleeding occurs mid-cycle. So looking at our patient, how long has she been on the birth control? 4 months. So does that qualify her to switch products at this point, or should we tell her to continue for another 3 months? We want to change at this point. It's starting in her active part of her cycle, so she's finished the placebo pills, now starting her new pill pack and still having bleeding, so that's considered early in the cycle. So we're going to need to increase our estrogen. So if we look at all of our alternatives here, we see that Merced's estrogen property is low. And so we need something that's going to increase that. We're already at high for progestin, so we really just need to focus on the estrogen property. And the only one that is a little bit higher is going to be the Orthocept, so we're going to switch to that product. So what would our answer be? Okay, our answer is B. All right, good. Okay, 37-year-old. This is on page 446. A 37-year-old woman is going to get married. She needs birth control pills now. She wants to have children within a year. These are things to keep in mind. Return to fertility. She has hypertension. She has GERD. Her meds, she drinks a little bit and smokes half a pack per day. You want to keep in mind the social history as well. Her medications include hydrochlorothiazide. She's on amlodipine, benazepril, also Prilosec, and her weight is 95 kilograms. Which one of the following contraceptive products is best to recommend to her? We have the transdermal patch. We have the oral tablet with drospirenone. We have oral tablet that's progestin only, or we have Depo-Provera or Depo-medroxyprogesterone acetate injection. So this patient was on drugs, medications. We need to assess if there are any drug interactions, and this likely will be on the exam, looking at drug interactions related to combined hormonal contraceptives. You want to note hepatic enzyme inducers, particularly rifampin. It's antibiotic that if it's being used, you need a backup contraceptive method, and then even 3 weeks after discontinuing the medication, they recommend a backup method as well. Anticonvulsant agents that are enzyme inducers. Of note, lamotrigine has kind of the opposite issue. Combined hormonal contraceptives actually decrease the levels of lamotrigine. So the patient could be stabilized on lamotrigine, and then you give them a birth control pill, and it actually changes the levels of the lamotrigine. St. John's wort or protease inhibitors can also affect the effectiveness, decrease the effectiveness of combined hormonal contraceptives. Things to do: we can use another hormonal contraceptive. We can use a different therapeutic agent, so it's such a different anticonvulsant. Though if the patient's usually stabilized on this, then we don't necessarily want to change that if we don't have to. We may want to just find a different hormonal method. And then using contraceptive with higher estrogen doses, usually with the 50 microgram dose, we could try that, but we do have to watch out for some side effects related to increased estrogen. Other drug interactions, so specifically drospirenone. This is a derivative of spironolactone. It is the progestin in some of the combined oral contraceptives. It can interact with NSAIDs or ACE inhibitors and increase serum potassium because it is a derivative of spironolactone, a potassium-sparing diuretic. The FDA did have a safety communication related to drospirenone within the last year or so, saying that there may be an increased risk of DVT with drospirenone. However, it's important to keep in mind that the risk of DVT with drospirenone is still lower than the risk of DVT with pregnancy. So in certain patients, drospirenone is kind of the better choice in terms of PCOS or androgen-mediated acne. So you just want to assess the patient's need for that progestin. Antibiotics, this is something that is fairly controversial. The latest guidelines say that the broad spectrum ones, such as amoxicillin, do not need a backup contraceptive method. However, if you're a conservative pharmacist like me, you may still want to recommend a backup method, though the guidelines say you don't need to. There have been some case reports of some contraceptive failure in patients, and it's hard to tell which patient might fail. So if you have a patient that is uncomfortable with that risk or develops breakthrough bleeding, then they definitely want to be using a alternative contraceptive. Others, the transdermal patch and the vaginal ring. The patch has had some controversies with it. It has an increased amount of estrogen than we originally believed. It also may have an increased risk of VTE and some other events because of this higher dose. As well, it's less effective in women that are more than 90 kilograms, so take that into consideration when you're looking at your patient case. The vaginal ring, that is a lower dose estrogen and progestin. It's inserted vaginally for 3 weeks, then it's removed for 1 week, the patient has her menses, and then a new ring is placed in. Some of the things to review with both of these products includes the missed doses or missed, if the patch fell off or the ring fell out. There's kind of a funny story that I tell every year that patient called up one of my colleagues and said, you know, I woke up and the patch was on my husband. What do we do? And that's okay, he probably got some estrogen, but the main thing is how long was the patch off? And so those are some of the things you want to review. You know, if it's more than 24 hours or if the ring's been out more than 3 hours, then some backup methods may be necessary. Some unique formulations are listed there on 439 through 441. The ones I want to bring your attention to include Natassia, which is quadriphasic. It has 4 phases or 4 levels of hormone. We have some that have folic acid, such as Safrael and Biaz, and then we have one that's very, very low ethinyl estradiol product at 10 micrograms. The next level up is going to be 20 micrograms, so this product is fairly low. Also reviewing extended regimens, we have the 3-month formulations and the 1-year formulation where the women will have less periods. One thing to keep in mind with those is that they're going to have much more breakthrough bleeding with those products than the others. Progestin-only pills, these are pills that are taken they must be taken at the same time every day. What I really just want to focus on and just remind everyone is that a 3-hour delay is considered a missed dose and would need a backup method. And so you may have a question like that. We have progestin-only injection that's given every 3 months. The side effects to be aware of include weight gain, some mood issues. Once you give this injection, you can't take it back, so you want to be careful with patients that might have depression. Also, it has a long return to fertility time. It's been reported up to 18 months, so women that are kind of later in their fertility age, older than 35, this may not be the best option. And then also possible decrease in bone mineral density has been reported, especially in younger women using it more than 5 years, so a calcium supplement would be recommended. We have the intrauterine systems, the Mirena and the Skyla. Mirena is inserted for 5 years and gives off levonorgestrel. Skyla is a new product that's just come out, and that is for 3 years and also provides levonorgestrel. The good thing about these is that they do have a quick return to fertility. We do have an implantable rod known as Implanon or Nexplanon, which is inserted subdermally in the upper arm. That's effective for 3 years. The difference between the Nexplanon and the Implanon is that Nexplanon actually is radio opaque, so they can see it on X-ray or on CT. And this has been important because some issues with the Implanon is after 3 years, tissue grows around it, and patients they have a difficult time finding it for removal. It has not been tested in women that are 30% more than their ideal body weight, so in women that are obese, this may not be an option. So going back to our patient case, what would be the best contraceptive for this patient? Any answers? No, I see some green, and that would be correct. The progestin only would be the best. It's going to have a quick return to fertility. The patch and the tablet have estrogen, and that's contraindicated for this patient. She's a smoker. She's older than 35 years. She also has hypertension. Also on benazepril, which is the ACE inhibitor, and the product had drospirenone in it. The depo-medroxyprogesterone acetate would not be appropriate because it does have a long return to fertility, and she's also overweight, and that does cause weight gain. Emergency contraception, this is unprotected intercourse within the last 120 hours. The labeling for the over-the-counter products is up to 72, but in practice we can do up to 120 hours. It's indicated for contraceptive failure, exposure to a teratogen, or sexual assault. It's not considered an abortifacient. It just prevents ovulation is the main mechanism. We have a variety of different regimens there. I just want to focus on the products that we have, the levonorgestrel or progestin only. We have generic forms that are 2-tablet forms that can be taken 12 hours apart or at the same time. We also have the Next Choice 1-dose or Plan B 1-step, which is just a 1-tablet, 1.5 milligrams taken as soon as possible. This is OTC for those that are 17 years and older, men and women, although recently it did change. The status changed to over-the-counter for all ages, and the FDA has about 30 days from the time of the ruling to change the labeling and make it OTC for everyone. Elaprestyle is a selective progesterone receptor modulator. Its abbreviation is SPERM, ironically, and its brand name is Ella, and it is indicated for 120 hours after unprotected intercourse versus 72 for the other labeling. And also it's prescription only, so it's a little bit different in that sense. And then the copper IUD can be inserted at a provider's office within 5 days of unprotected intercourse. We're going to switch gears now and talk about sexually transmitted infections and diseases. The guidelines are there in your booklet there. I do recommend reviewing this. They have a lot of information, much more than what I can provide in the chapter. We're going to start with herpes simplex virus. Generally, the therapy is used to control the symptoms. It doesn't change the patient's risk or frequency or severity of reoccurrences. The virus remains latent in the sacral dorsal root ganglia, so can it reappear? The initial infection, we can use acyclovir either in a higher dose with less frequent times or a lower dose more frequently. Famciclovir and valciclovir are also available. For recurrent HSV infection, so this is after their initial one, they get another one. If the patient gets therapy within 1 day, that tends to be much more beneficial than if they wait longer. If you look on page 452, there's a list of all the regimens there. For suppressive therapy, we use this for patients that have had 6 or more within a year. So they just keep getting recurrent infections for whatever reason. And in this case, we're going to use a lower dose of the treatment drugs and give that every day to make sure that they don't continue to have flare-ups. So on page 452, patient case 8, question 9. DH is a 21-year-old woman who presents with genital itching and vesicles on the vulva. She usually sexually active with one partner who has a history of herpes, and he does not always use a condom. She was initiated on acyclovir for her initial herpes infection. So which of the following statements best to mention to DH? And the answer there is B. I didn't do cards on this one. But the treatment will shorten the duration of the symptoms and infectivity of the initial infection. As I said, it doesn't decrease the risk of recurrent infections or the severity or prevent the virus from remaining in the dorsal sacral root ganglia. Patient case 8, the same patient, question 10. DH returns to the clinic 10 months later, and she is having more recurrences, 7 to date. So which of the following would be the best therapies to recommend? So I'll give you a chance to look at this and see if I get any answers. Okay, I'm seeing some yellow, and that would be correct. It's going to be suppressive therapy. The reason for that is because it's more than 6 in the year. The other answers are treatment doses, or the suppressive and suppressive therapy is a lower dose, which would make the choice D the correct answer. Other sexually transmitted infections to review include syphilis. So there's primary. We also have several different types of syphilis if they're not treated appropriately, and those are listed for you in your handout. The drug of choice is going to be benzathine penicillin G. We do have some alternatives such as doxycycline if the patient can't take penicillin, and there's some others that are listed there as well. Chlamydia, unfortunately, is one of the more common sexually transmitted infections, probably one of the highest in the younger age group, and we're seeing more and more of that. Azithromycin 1 gram in a single dose is going to be the drug of choice. Alternatives can be doxycycline. Gonorrhea, this is somewhat of a change. It went up from 125 milligrams of ceftriaxone IM to 250. So about 3 years ago, this change took effect. So you definitely need the higher dose. Recently, there's been an update in the guidelines. You used to be able to use cefixime 400 milligrams orally as well, but they're starting to see more resistance to the oral agent, so they're recommending to avoid oral agents. You only use the oral agent if, for any reason, the patient can't get ceftriaxone. You also want to use azithromycin 1 gram to rule out, if you can't rule out for chlamydia. So you usually treat the two together because chances are if the patient has gonorrhea, there's a chance that they're going to have chlamydia and you don't want to miss that. So you treat them with both ceftriaxone 250 IM and then azithromycin 1 gram. So if you do get a patient case like this, that's something to think about. Fluoroquinolones would not be used in this case because there is a high resistance rate. You also want to recommend that the patient abstain from sexual intercourse for at least 7 days until both partners are treated. Some complications that can occur if the patient's not treated adequately can be urethritis, prostatitis, or pelvic inflammatory disease. So patient case 9, question 11 on page 454. MA is a 24-year-old woman. She comes in with abdominal pain. She's having dysuria, vaginal discharge. She's sexually active with multiple partners. Her past medical history is unremarkable, except for recurrent genital herpes. Medications include oral contraceptive, fluticasone, and we have her vitals there, as well as she's presenting with some tenderness and vaginal discharge. So which of the following would be the best empiric therapy? We have ampicillin, sulbactam, 2 grams IV Q6 for 14 days, metronidazole 500 milligrams IV 3 times a day for 7 days, cefotetan 2 grams IV Q12 with doxy, or ceftriaxone 125 milligrams IM with doxycycline for 7 days. So let's talk about pelvic inflammatory disease. Generally, we start off with parenteral treatment. Once the patient starts to have symptoms that improve, we discontinue that within 24 hours, switch to oral therapy for 14 days. If possible. So the first regimen is going to be cefotetan 2 grams IV Q12 or cefoxitin 2 grams IV Q6. Plus we need to have doxycycline. We start off intravenously and then switch to oral. If the patient cannot tolerate cephalosporins, we can use clindamycin plus gentamicin as an alternative. Some other alternatives include sulbactam 3 grams IV Q6 with doxycycline. Or we can do ceftriaxone IM, 250 milligrams, or the cefoxitin plus probenecid, and also add doxycycline. We can either add metronidazole or not, depending on the patient. And the treatment is going to be for 14 days. So it's important to remember what the treatment times are, especially in the answers that you have to choose from. Sexual partners for pelvic inflammatory disease patients should be if they've been active within the last 60 days, should be treated as well, evaluated and treated. So looking at our choices here, which of the following would be the best empiric therapy? Okay, I'm seeing some green, good. It's going to be our cefotetan 2 grams IV Q12 with doxy for 14 days. The other choices, the sulbactam, the 2 grams is not enough. We're going to need at least 3, and then we also need additional agents. Metronidazole alone is not enough. Then ceftriaxone 125 milligrams IM, we need to bump that to 250. As well, the timing, 7 days is not enough. It needs to be at least 14. Some other infections to review, bacterial vaginosis or BV. Metronidazole or clindamycin are going to be your drugs of choice here. The symptom that the patient usually complains of and that kind of leads the physician to figure out what it is usually a malodorous vaginal discharge, usually a fishy odor, and that tends to be BV or bacterial vaginosis. Treatment of sexual partners is not necessary. In pregnant women, we do want to avoid using the clindamycin vaginal cream. We can use the medication itself systemically, but not the vaginal cream. For some reason, the cream has shown to increase risk of preterm labor. For trichomoniasis, metronidazole is our drug of choice. We could also use tindazole. In this case, the patient, their sexual partner should also be treated. And this is a little bit different. Within the last couple of years, before it used to just be the woman that was treated, but now we treat both partners. Vulvovaginal candidiasis, this is our yeast infection. We have a variety of over-the-counter treatments as well as oral fluconazole. Usually presents with intense itching, beigey, white, milky discharge. The key here is that if the patient has 4 or more in a year, then at that point usually the patient needs to be evaluated for some type of immunocompromised disease such as HIV or possibly diabetes could be causing these vaginal infections. And our last topic is going to be male sexual dysfunction. This is going to be page 460, question 13. It's a 65-year-old man who presents to his physician complaining of symptoms determined to be erectile dysfunction. He has a history of hyperlipidemia, GERD, and glucose intolerance. His medications include atorvastatin, omeprazole, aspirin, and He heard that there are medications to help with his symptoms, but he doesn't want to have to plan out his intimate moments. Which of the following drugs would work best for this patient? So we have our options: tadalafil, avanafil, yohimbine, or bupropion. Male sexual dysfunction can be caused by a variety of different things. Reduced libido can be from an organic or psychological cause. You could have low testosterone levels or high prolactin that could cause issues. So if you have a patient case, you want to look and see what, if they give you a testosterone level. If it's low, then that may indicate supplementation is necessary. But if it is normal, then you will want to consider some other agents. There are different types of sexual dysfunction. There can be ejaculation or erectile. Premature ejaculation tends to be one of the more common ejaculatory issues. And then erectile dysfunction can be psychological, organic, or mixed. Also, drugs can cause erectile dysfunction as well. You want to treat the underlying disease if possible, or what's causing it. You want to control the risk factors. So this can be smoking, if they're overweight, if their diabetes is not controlled, hypertension is not controlled. We have some non-pharmacological agents that we can use, such as vacuum devices or constriction rings. Pharmacological options: if the patient has low testosterone and needs testosterone supplementation, we have those replacements. It would be good to review the types and their application instructions, as well as things to monitor. They can cause liver toxicity or increase lipids. And so in those patients, you would be wanting to monitor for those things, as well as you want to avoid it in patients that have had a history of prostate cancer. Yohimbine is an herbal product that it's not really recommended. The guidelines do not recommend use of this product, but it is available over the counter, so patients may be using it. Some of the side effects include anxiety, insomnia. Alprostadil injection or pellets, these are usually inserted into the urethra. And it's prostaglandin. It causes vasodilation and allows more blood to the area. SSRIs are generally reserved for premature ejaculation, and the EMLA cream or lidocaine cream can also be used for premature ejaculation. The gold standard or drug of choice, usually for sexual dysfunction, given the other issues are ruled out, is the phosphodiesterase type 5 inhibitors. Things to watch out for in these patients: it's contraindicated with nitrate use. Also, you want to caution in patients that have cardiovascular disease. Also, you want to look and see what drugs the patient is taking. Some of the drug interactions with CYP3A4, such as macrolides, azole antifungals, or protease inhibitors, these can increase the levels of the PDEs and cause some severe side effects. So you want to look out for those, especially in their questions or in your patients. Concurrent use with alpha antagonists may cause hypotension. So again, if your patient is on that, you may want to adjust some things before starting them on this medication. They may require hepatic or renal dose adjustments. And vardenafil in particular may cause QT prolongation, so you want to be careful if there's other medications that can increase QT prolongation, as well as avoiding it with class 1A or class 3 antiarrhythmics. And generally we're trying to avoid it in cardiovascular patients anyway, so hopefully there won't be that interaction. So list here for you, kind of looking at the different agents. Of note, all of them usually require hepatic dose adjustments, with the exception of avanafil. Avanafil is one of the newer agents. We also have vardenafil, which is a disintegrating oral tablet, but it is not interchangeable with Levitra, the vardenafil, just a regular oral dose. All of them are usually given about 30 minutes to an hour prior to intercourse, with the exception of tadalafil, which can be given up to 36 hours prior to intercourse and can also be done in a low daily dose. So that can help some patients if they don't want to plan out their intimate moments. So going to our patient case here, which of the following drugs will work best for this patient? Okay, and yes, A, tadalafil. Tadalafil is the only one that could be dosed either a low dose daily or up to 36 hours prior. Bupropion would not be appropriate. That's usually used for women that have some sexual dysfunction. Yohimbine, we recommend against that, and avanafil, you have to do it within 30 minutes to an hour. And with that, I will conclude.